Good morning, everyone. Welcome to the Changing the Way We Work community of practice for Ontario family physicians. My name's Ali Damji, and I will be the moderator for today's session, which is focused on infectious disease and navigating Ontario's disability support program, as well also featuring some updates on AI in healthcare. We're very pleased to continue offering these sessions on behalf of the Department of Family and Community Medicine from the University of Toronto in partnership with the Ontario College of Family Physicians. I'm going to turn things over to Jobin, the president of the OCFP, to introduce the session.
So much. And so we have a jam-packed agenda, and so I won't spend too much time, but Ali is going to be speaking about each of our panelists, and they're going to be introducing themselves. I just wanted to give that quick heads up that because of the CERT Plus platform changes, there are some delays with regards to the credits, but we will make sure that that gets inputted. Next slide. I want to give the land acknowledgement here to say that we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. On behalf of our group here, I wanted to sincerely apologize for the last minute cancellation of our February 7th community practice session. We recognize that your time is valuable, and we deeply regret any inconvenience it may have caused. Moving forward, we're committed to improving our communication so that you receive timely and clear updates should unforeseen circumstances arrive. We've rescheduled the session for March 7th, 2025, and we hope you'll join us then. Just in reflection, apologies are always only a first step. We need to have true accountability within our own actions, whether it's in reconciliation, healthcare equity, or professional commitments. Words can lead to meaningful change. And as family physicians, our roles need to extend beyond the recognition of harm. We must act to improve access, dismantle inequities, and rebuild trust. And with that, I'll hand it back to Ali.
Thank you so much. So in terms of these sessions, just as a reminder to everyone that these are accredited sessions, and I just want to also take an opportunity to thank the planning committee who helps us put together each of these sessions. Next slide. So this will be the order of our panelists today, and very shortly they'll be introducing themselves to you. So we'll be starting with our infectious disease speaker, followed by a talk on AI, and then following that, we'll move over to ODSP. Next slide. So first, I'll turn things over to Dr. Vaisman to introduce himself.
Hi, thank you for having me. My name is Alon Vaisman. I'm an infectious diseases and infection control physician from University Health Network, and I have no additional disclosures.
Thanks. Over to you, Dr. Alarakhia.
My name is Mohamed Alarakhia. I'm a family doctor in Kitchener and the CEO of the eHealth Center of Excellence.
Excellent. And then next over to Norma English.
Good morning. My name is Norma English. I'm Director of Legal Services as well as a lawyer with North Peel and Dufferin Community Legal Services, and I have no further disclosures.
Great. Thank you all for being here. Next slide. Jobin, over to you.
Very quickly, I'm the president of the Ontario College of Family Physicians, and I have two roles within TMU and William Osler. I'm interim assistant dean of primary care education and associate vice president of academics. Thank you.
All right. And for myself, I hold a few different roles, including being involved with the OCFP in this role, the Ontario Medical Association on their committees, my hospital, Trillium Health Partners, and the Canadian Mental Health Association for Peel Dufferin. And I'm on the board for the Center for Effective Practice, as well as the Foundation for Advancing Family Medicine and the Medical Post-Medical Advisory Board. And I've received a one-time honoraria from GSK, which is not an ongoing thing. Next slide. So in terms of how to participate for today, just a reminder to our participants to please put your questions into the Q&A. I already see some of you have already been eager in doing so, so thank you for that. And if you see a question on the Q&A that you'd like to be asked, please use the thumbs up button to upvote it so I can see it as the moderator, because I will ask the questions that have the most votes. A reminder that the chat should only be used for networking and communicating with one another, not for asking questions. Please put them into the Q&A. Next slide. So with that, we're going to turn things first to Dr. Vaisman. over to you. Next slide.
Hi, thank you. I'm Alon from Infectious Disease. So we'll talk about viral respiratory infections. And to give you an overview, next slide. We're talking about the current state of viral infections. We'll try to do as little talking as possible. We'll try to show as many pictures as possible. Next slide. So if you look at the Ontario website, next slide, you'll see the current data for the viral respiratory activity in Ontario. It's all numbers, but on the next slide, you'll see what the current trend is. The most important thing to glean is that we've had quite a significant flu season, so more so than previous years. This was also true in the United States. What's also interesting about our flu season this year is that it was delayed in its peak compared to prior years. So usually in the prior pandemic years, we see an influenza peak in the last week of December, first week in January. This week, it came approximately 3 weeks later. So fortunately, although it didn't come on with a COVID peak, but it did also come with a an RSV peak as well. So flu and RSV seem to have a higher activity than normal this time, with a peak that was longer with flu. We're still seeing significant number of cases in flu even into February. On the next slide, you'll see how this has impacted outbreaks across the province and how many cases we're still seeing in terms of percent positivity. Actually, the outbreaks haven't been as high necessarily with COVID, so that was good news scenario. But again, with flu, it was a significant number. Next slide. So where are we at with vaccines? So on the next slide, you'll see the COVID vaccines. I just want to make one correction to the slide is that the AstraZeneca on the bottom left is no longer approved, but we do have the 3 other vaccines. So it's just those 3 to think about. In terms of prevention of COVID, you saw that the numbers are quite different than they were in previous years. We know that COVID is a less pathogenic virus than it was in 2020. So we're almost reaching the 5-year anniversary of COVID arriving in Canada. And we know that now the virus is quite different. As a result, the NACI statement, which has been as is for more than a year now, recommends that people who are over 65 and people with risk factors for severe disease are the ones who should get vaccinated every 6 months. For those individuals who don't have any specific risk factors, who don't meet the age criteria, the phrasing is now may. So instead of saying should, it's now may. And that's critical because when you're counseling your patients, you think about where is the biggest bang for your buck in terms of spending time counseling patients who may be opposed to vaccination or vaccine hesitant. The biggest bang for your buck is in that high risk group. The lower risk group doesn't have as much benefit anymore, certainly not the mortality benefit that we saw earlier in the pandemic, and especially younger people like kids where the mortality rate always has been very low and remains very low. So in terms of COVID, really the vaccination should be targeted towards high-risk individuals where there is still a benefit in vaccination every 6 months. On the next slide, you'll see the other types of vaccines we should be thinking about. Some of these are also seasonal, so influenza. Basically, anyone over 6 months should be receiving the influenza vaccine. We know that influenza vaccine protects you against the flu during this season, and to some degree, depending on the strains that follow the next seasons, it also protects you against future episodes of the flu. It also reduces the severity of illness. So a lot of patients tell me, I got the flu vaccine, but I got the flu anyway. But keep in mind that the severity of illness is also reduced. RSV was a key, as I mentioned, a key player in the respiratory viral season this year. And we know that there's a vaccine that was developed and available as of last year. As far as we know now, the recommendation from the federal government is that patients should receive the RSV vaccine at least once in their life. It's only been around for 2 years, so once in your life really just means once in the last 2 years. In the future, more data will present itself about how frequently people should be vaccinated against RSV. But for now, it's just receiving the 1 dose. And in Ontario, it's covered for people who are at risk. So basically vulnerable patients and elderly patients, patients living in LTC or in rehab settings. Shingrix is another one that we don't often talk about, but we're seeing more and more varicella exposures because more and more patients are immunocompromised and vaccine rates among young patients is unfortunately decreasing. So Shingrix provides protection against reactivation of varicella, so reduction of shingles. And this is covered for patients in Ontario for 65 and 70, and it's indicated for anyone over 50 because the likelihood of having a reactivation is higher at that age. Pneumococcal is one that we often forget. Of all of these 4, pneumococcus is one that we don't think about very often. But the indications for pneumococcal vaccination are clearly laid out by NACI. In this sense, without getting into a lot of details, patients who are at higher risk, patients who are older, of course, and patients with risk factors for pneumococcal disease who've had some kind of immunocompromising situation, for example, splenectomy or other immunosuppressive use. And of course, we give it to infants as well. So when you're counseling patients and you're thinking about vaccination on a recurrent basis, think about these 4. Of course, some of them are only given 1 time, but think about whether you've talked to your patients about it. Next slide. So the last thing I wanted to talk about is bird flu. So on the next slide, you'll see some pictures of birds. We can go through what each of these birds are. The moral of the story is that all these birds can be transmitting bird flu. So chickens, so flocks of domesticated birds on farms. You have geese, you have ducks. They're all bad. All these birds. Why are we talking about bird flu? The reason is that in the last 5 years or so, the number of cases of bird flu have rapidly increased across the entire world. If there was such a thing as bird Twitter, it would be going viral. Get it? Viral on bird Twitter, because the number of flocks affected are now vastly increased. In North America, South America, in Asia, Africa, bird flu is spreading significantly. It's also spilling over into mammals, so into seals, into cats, into dogs, and of course into cows, which is what we saw in the US in the last year. So now the likelihood of people being exposed here in North America is vastly increased compared to what it was before, where we're seeing it primarily occurring in people in Asia, Southeast Asia, where the highest number of bird flu cases were first seen. On the next slide, you'll see what I'm talking about with bird flu. So if you think about all the influenza strains, we know that there's A, B, C, and D. Bird flu is really what we're talking about is influenza A. Influenza A can roughly be divided into viruses that come from swine and roughly into viruses that come from birds, although there's viruses that can be found in other animals. You're all familiar with H1N1 because it was the most recent pandemic was 2009. And now it's become the most common circulating strain, and it's found commonly in swine or in pigs. And then some of you older family docs in the audience may also remember when you were practicing back in 1919, it was the Spanish influenza back then. Some of you may remember that. So H1N1 is now the predominant strain that we're seeing from year to year, but avian influenza is a different set of strains of influenza, predominantly in the groups of H5, H6, H7, H9, H10. This is just kind of a nomenclature that we use to identify the file strains. Of these avian flu, you can subdivide them into either high pathogenicity or low pathogenicity. The high pathogenicity is the one we worry about because the mortality rate is extremely high. You may have heard of some of the more common high pathogenicity ones like H5N1 and H7N9. So in the next slide, you can see what I'm talking about here, a mortality rate of 50 to 60%. So these strains, which only make up a small subset of all bird flu, are highly likely to cause high mortality. So there haven't been that many cases across the world, but of the ones that have occurred, the mortality rate is high. In Ontario, we don't really need to worry a lot about it in urban settings because the most likely setting in which a person in Ontario will be exposed is from farms. So they have detected the bird flu across Canada in bird reservoirs, mostly in southwestern Ontario, but they're across Canada. If you look at the PHAC website, you'll see where it's been found. And in the United States, it's also been found commonly across other sites in the livestock as well. So when you're thinking about it in your clinic, it's fairly unlikely you're going to see a case of bird flu in your clinic, but suspect it if the patient is very sick or if they've had an exposure. Some of you may be practicing in more rural settings, or some of you have patients who keep birds. That's where you really should be worried. And of course, call public health if you're worried about a patient who may have had bird flu. There are certain things that they will do, like they'll test it. They'll be more keen to do the subtyping testing if you are indicating that you suspect somebody who has bird flu. And of course, send them to the hospital. Why send them to the hospital? Because the mortality rate is high. And of course, because you don't know what type of flu they have. With flu in certain populations, the mortality is high, so we want to make sure that they're in the right setting. But I think the overall conclusion for the family medicine population or family physician community is that the likelihood you're going to see it is very low, but really think about it in patients who have risk factors. So in conclusion, on the next slide, basically the influenza season this year was quite significant, associated also with a significant RSV season. Remember, in your elderly population, there's not just flu and RSV and COVID to think about. There's also pneumococcal vaccination and Shingrix to think about in terms of things that are common. And then lastly, don't trust a bird. Thank you, everyone.
Thanks so much, Alon. Loved the humor as well too in this as well. It was great. So we have lots of questions for you. So I'm gonna just jump right in. So the first question here is regarding testing in the community. Not sure if you're as familiar with this, but like in terms of testing for COVID, RSV, and flu on patients, are these tests that can be done in community settings, or do they have to be done in the hospital? Oh, Alon, you're muted.
Sorry, thank you.
No
Rookie
worries.
mistake. I think it depends on what your goal is when you're thinking about testing. There are certain populations where, for example, for COVID, they are a candidate for early therapy, for antiviral therapy, because it modifies their risk. And in that setting, the Ontario government is well aware of that. And in pharmacies, COVID testing makes sense for somebody who you think is a candidate for, let's say, molnupiravir or other antiviral therapy. So if it's for flu, for example, if a patient is sick enough to require therapeutics for flu, they should be going to the hospital, in which case they should be tested there. RSV, we don't have readily therapeutics for most people, only very severely immunocompromised individuals. So really the setting in which you want to get a patient tested for RSV is one where they are sick enough to be in hospital. So that's really what your approach is. How does it tie to therapeutics and severity of illness?
Great. Thank you so much. So a question on the bird flu. So should we be wearing N95s in this situation? I know you just said it's quite rare, but should healthcare workers be, taking additional precautions in light of how serious the mortality is with it?
As far as we know, there isn't any difference. Hasn't been well studied because there hasn't been many cases of bird flu, of high HPI bird flu across the world. So we don't really know the difference. There's no really harm in the very short term if you suspect it in a specific patient. But across the board, in terms of your routine practice, I wouldn't recommend use of an N95 for a routine practice nowadays. So it's really at very rare instances where you may suspect it. But again, it's a very unique subset of patients that we haven't seen in Ontario. We haven't seen HPAI in Ontario.
Okay. And then this is now sort of a crystal ball question, is that how likely do you think this will become a pandemic?
The one thing I didn't mention during the talk is that the one feature that's preventing it from becoming a pandemic is human-to-human transmission. When COVID took off, when it did, was because it was readily transmissible between humans, and it became extremely transmissible. That has not been seen, as far as we know, with HPAI. With the other strains of flu, obviously, there's human-to-human transmission. Not as good as COVID, but still, obviously, there is. But that's really it. If that ever happens, or if somebody in a lab somewhere is doing that, then that's the ball game. So there's no way of predicting whether that's going to happen. The only thing that has spared us so far is that feature alone.
Mm-hmm. And I guess then there's this other question here around, like, when would healthcare workers be vaccinated? I'm assuming that would be if that were to happen, right?
Right. So the Canadian government just this week purchased 500,000 doses of a strain that we suspect will be able to cover you against H5N1. So presumably the strains that are HPAI as well, which just to say clearly is that not all strains of H5N1 are HPAI, substrains of it are. So the current approach from the Canadian government hasn't been released, but presumably they would start with high-risk individuals, those working on farms. But I hope the Canadian government and the provincial government are thinking about who else would be at risk aside from farm workers. It would also be healthcare workers. So they don't have a plan released yet about how they would release that vaccine that they purchased, but hopefully they would include us.
Thanks. So going back to the advice you were giving around vaccines, would we still be recommending COVID vaccines for pregnant women?
Yeah, so in the NACI guidelines, you could include pregnant women in that population. I think there's very little risk because when we talk about the vaccines that we're using now, of course, as I mentioned, AstraZeneca is no longer an option. The mRNA vaccines are quite safe, and for pregnant women, there isn't a high risk of any side effect, more so than the average population. So I would have that discussion with pregnant women, especially if we're during a wave of COVID, as we occasionally are throughout the year. I think it certainly makes sense to have that conversation. You probably have, again, higher bang for your buck discussing that with a pregnant individual compared to, a child who's 12 years old, for example, where the likelihood of mortality benefit is lower.
Mm-hmm. Makes sense. Definitely sort of, as you said, tailoring it to the populations that would most benefit from it, as you said. Yeah.
Yes.
And then in terms of the RSV vaccine, do you know if coverage is going to be expanded? Right now, as you said, it's only for certain populations that get coverage.
Yeah, it's a very good question. I myself, I don't know. I'm not party to those conversations, so I don't know if it'll expand. I think the way it's been designed is based on what was studied in the clinical trials. And if there was new data that suggests that patients outside of that criteria benefit from RSV vaccination, that would make the case for the government to cover additional people. That's not to say you could pay out of pocket for people who aren't covered. But in terms of what they would cover, my guess is just that it would be based on the new clinical trials that would happen.
Great, thanks. Another question here about RSV. So, when is the RSV season anticipated to be over? When do we stop offering this vaccine to older adults and Beyfortus for infants? Is there any indication, or from your perspective, around infectious disease patterns, do you think that would ever happen?
Yeah, so the RSV activity is generally the same as flu. So between November and March, November and April is generally when it's highest. And this year, as I mentioned, is particularly high. But the vaccine is available, so you could get vaccinated any time. We just don't know the mechanics of the vaccine yet, whether if you got a vaccine in July, how does that differ from getting it in October? Presumably, you would be more beneficial to get it closer to the time of the RSV season or the winter season. But we just don't have that data yet. So it certainly makes sense to do that during flu season. It certainly may have that top of mind when patients are coming in to talk to you in September, October. You have that conversation about whether they're a candidate for COVID, RSV, and then obviously getting the flu vaccine for everyone.
Mhm. And then in terms of like COVID, just going back to that again, there's a question here about around COVID being less harmful than it was. So what do we know right now about how harmful it continues to be? Because there seems to be some mortality with it. There still seems to be people going into the hospital with it, and it still has the long COVID aspect to it. So in terms of like, I guess our risk stratification and what you were saying before too, around the fact that certain populations are at higher risk, I guess how do we sort that out in our minds?
Yeah, the best thing is to use the NACI definition of what they deem as high risk. It is still quite expansive, but basically their definition of high risk includes intuitively who you might think. So people who are over 65, people who have recent transplant, who are chemotherapy for a malignancy, people who live on reserves, for example. So that still is, the data is still showing that those people are still at higher risk for poor outcomes. So the mortality rate remains higher than the average population, but lower than it was for those same populations back in 2020. So I would approach the question of high risk based on that criteria. And yes, people are still dying, but the scope of it is so much smaller than it ever was. The number of people we see now in the hospital, like on ECMO, for example, is extremely rare with COVID compared to where we were before. And in terms of the second question, with long COVID, we just don't know whether vaccination is going to be effective at this stage because the number of infections and vaccinations people have had, there's so many permutations that there isn't really a clean way of studying it. Although if we did an RCT, that would be a very good way. The problem is that the drug companies are no longer incentivized to do big studies like they did. So we don't have the high quality data for long COVID to see whether it actually makes an improvement in that front.
Great. Thanks so much for that really detailed answer. Is there a benefit at all to giving people flu shot boosters if they got their flu shot early, given the later peak this year?
Very good question. As far as we know, we would only give, it's only been studied that you'd give one dose in this setting. So the way that the flu vaccine rollout works is based on where we guess the peak would be, which is usually end of December. There is no sort of role for flu boosters at this stage. Maybe that'll be studied in the future in a more rigorous fashion. But yeah, if a patient comes to you on October 15th, the first day that the flu vaccine is available, let's say next year, and you offer them the vaccine, it's perfectly fine. It'll cover them for the period that we suspect that there'll be high flu activity.
Great, thanks. I love this next question. So, should we stop feeding the birds with our bird feeders?
It's not those birds, but yeah, it could be those birds. Just don't come close to them. Look them straight in the eye. See if they have the evil in them. There are surprisingly high number of Torontonians and people in the GTA because according to the law, you can keep a certain number of birds in your backyard. And a lot of people also are hobbyists. They keep birds like they have farms in the rural areas. So that's really when you want to do that history. Also, there's some degree of people who are marginally housed, who are homeless, who may be exposed to birds like pigeons and other things. So basically, almost any bird can be infected by bird flu, and that's where the history would come in. You're really looking for something significant. And the interesting thing about it is that people are exposed to cows for some reason, did not have severe illness in the US. These are the case in the US. The humans did not have severe illness when exposed to cows, but most of the other HPI cases when they're exposed to birds did have severe illness. We don't know exactly why that is yet. Maybe it's the mode of transmission from bird to human. Maybe it's the fact that bird flu is very high mortality in birds. In case you're curious, 90 to 100% of birds who get HPI die. So the viral load must be very high in these birds because they're dying, whereas in cows, it's not the same mortality rate at all. So there's something special about a bird to human exposure that results in severe illness in the human. In any event, try to think about risk factors. And when you suspect a patient who has flu in your clinic, 99.9% of the time, right, it's not going to be the case, but just ask some questions about risk factors.
Great. I think that's such a valuable take-home message for all of us as well. Just because it's not something that we often think about. I never thought I'd have a community of practice that'd be so focused on birds, but there you go. So
one other really critical question I just wanted to say is that between March and September, or March and October, when we expect very low flu numbers, that's when your radar should be really high. Because if you see a flu case in June, that is very bizarre. And that, or a suspected flu case, so they meet the case definition of flu, like myalgias, prostration, runny nose, cough, rhinorrhea. That's when you should think, well, what's going on here? And in fact, the Ontario government screens all those cases that come in. Instead of doing a sampling, they subtype all of them, because it's so bizarre that you'd see flu during that time that the likelihood of it being HPAI is probably increased. So that's one of the things to just keep in mind. If you see a flu case during non-influenza season, think about the exposure risk.
Great, thanks for that. That's a very helpful tip. I'm going to ask you two more questions, and then we'll move to our next speaker. These are both related to vaccination. So the first one is around Shingrix. So Nasi used to say to do Shingrix at 60-year-old if you could, despite the monograph saying 50 plus, and as you mentioned as well in your talk. This was to ensure immunity as you age. So cost aside, what is the ideal age to vaccinate someone with Shingrix?
Yeah, it's a good question. So after 50, we see kind of your risk of having reactivation of shingles exists even as a young person. So if you had chickenpox as a child, you could get reactivation at age 20 and 30, but that inflection point is 50. That's when you see the inflection point of reactivation go up. Your lifetime risk is about 1 in 3 of having reactivation. So as you age, that risk potentially accumulates, because also you're more likely to be exposed to immunosuppressives. The way that the Ontario government has designed in terms of who they're covered in their 60s is a sensible approach, because it's a area where you see roughly where we saw the highest numbers of reactivations in the clinical studies. But essentially, it makes sense to aim there because it's also covered. If the patient has a reactivation, they can get boosted again after 1 year. So it's not as though if you have shingles, you can't get Shingrix. You can, you just have to wait a year afterwards. So I would use the current coverage model. And if a patient isn't covered in that time frame and you think they're indicated because, let's say, there's other risk factors that you're worried about, then you could just advise them to pay for it. Unfortunately, we don't have coverage for everyone in Ontario, but that probably makes sense in terms of the target age in the 60s, because you're balancing out not waiting too long and not doing it too early.
Mm-hmm. Thanks. That's very helpful. And then the last question I wanted to ask you here, although there's still a lot in the Q&A, so feel free, Alon, if you want to type answers to them afterwards. But this last question I'll ask live is that if patients over 65 have had Prevnar 13 and or Pneumovax 23, should they now also get Prevnar 20 now that it's covered? And if so, when would you recommend it? And when would it be publicly funded?
Yeah, if they received the vaccine series as described in that question, they really don't need to have the additional one. So that's what's currently recommended. But if I'm wrong, or if there's any changes to that in the future, then it's important just to check the NACI website to check whether there's any modifications to that recommendation.
Yeah, that was my understanding as well. Like if they've had Prevnar 13 and Pneumovax 23, they're considered fully vaccinated, so then they wouldn't be eligible for Prevnar 20.
Right.
Okay, perfect. All right. Well, I think that's hopefully the correct answer if we both thought the same thing as well. Awesome.
Yes.
All right. Well, thank you so much. And yeah, feel free to answer more questions there. I'm just going to pull up the slide deck as well, and we'll move into our next slide. There's just a quick thing I was going to speak to, and then we'll move over to Mohamed. So just in response actually to the questions we receive on a regular basis about long COVID or post-COVID syndrome, there are now Canadian guidelines that exist for it, and they will be released by March 31st, and they highlight these different topics here. So stay tuned. There's also going to be live webinars and a whole resource page as well too, and they're coming out from McMaster. So definitely check this out, because I know this is an area that a lot of us have questions about and that we see in our practices. And with that, I'll turn things over to Mohamed.
Thanks very much, Ali. So a little bit of a different topic. We're going to talk about artificial intelligence in primary care. This is a rapidly evolving field, and all of you have seen the buzz around AI. I truly believe it is a game changer for primary care, and I'm going to give you some examples of where it is being used and where it will be used moving forward. So we'll go to the next slide. My hope today is to really give you some practical considerations of using AI in practice. So what should you be aware of when you're having EMR vendors and all these companies talking to you about AI? And then talk to you about some really practical things in terms of how to support inbox management, where are AI scribes going? I know you've had a discussion about that before, filling forms, and we're going to see the ODSP form later on. And so this is really talking about how the solutions may help with that, and then happy to sort of take some questions. I will disclose AI was not used to make this presentation, but AI is great for making presentations in terms of making up images and getting content as long as you look at the references. But that's another topic in and of itself. We'll go to the next slide. And so when you're thinking about using AI in practice in general, and I would say that you are going to be using AI in practice in the future, and I think family medicine is really well positioned to leverage the tools if you have the right framework and the right safeguards in place. And so this is an evolving conversation, and there's guidance out there from the Ontario College, from CMPA, and I would encourage you, and we can circulate some of those links afterwards so that you can take a look at that. But in general, the things that you should look at when you are considering an AI tool in your practice is first in terms of the data. Ideally, the data should be stored in Canada. Once the data leaves Canada, say it goes to the US, there are less safeguards protecting that data. And so while you can do that, while you can use technology that stores data in the US, you have to let patients know about that and the risks around that, which gets a little bit complicated. So when you are signing these contracts and looking at vendors, make sure you ask if the data is stored in Canada or not. In terms of how long the data should be stored, if you are using an artificial intelligence scribe, which I know a lot of people are trying out, it should only be stored for as long as needed. So the recording that the AI scribe is making when you're talking to a patient should be destroyed almost immediately. Like it should not persist for a long period of time, because it does get more complex if you have a recorded conversation and then you have a note in your chart. There's now two sources of truth, and you've got to be cautious about that. The actual node in the AI scribe, so when you do it in the AI scribe, you will then put it into your medical record. That data usually should be less than 30 days that it's stored, so you could retrieve it if something went wrong, but it shouldn't persist. Again, you don't want two sources of truth. You want your medical record to be the source of truth. And as we explore other tools, there's similar principles that will apply, is that you want your record to be the source of truth. The third point is you need to control the data, and you need to be aware of if there's any secondary use of data. If the data is being used to make the AI better, making the model better, you need to make sure that you are aware of that, and you let patients know that if that's the case. Ideally, the data should not be used to make the large language model, the AI, better. It should be used to produce what you need to produce. In the case of a scribe, the note, and that's it. The vendor should comply with all privacy regulations in Ontario. That's PHIPAA. There is federal legislation as well, PIPEDA. You want to make sure it complies with PHIPAA. So when you practice Ontario, you want to make sure it meets Ontario privacy regulations. And then finally, if you're using tools where you are interacting with patients and those tools use AI, you need to get consent from patients. For an AI scribe, the first time, not every time. You get it the first time, you document that you've got consent, the patient's full aware of using that you're using AI in your practice to transcribe notes. You don't need to keep on getting it. It may be it's my practice, and to tell the patient, I'm using that tool that I used last time to take our conversation and make a medical note, just for awareness. So you could sort of have that. It's a very short conversation. At subsequent times, most patients are, I know you're using that. Just use it. Don't ask me. But it has to. The patient has to understand. What are you using? What are some of the challenges? And I have a script that I will put into the chat later that just sort of goes through what you should be saying about an AI scribe, for example. And then other tools that we'll talk about now in the next few slides, where the AI is sort of in the background, like the inbox. You don't really they're starting to become part of the tool. And that's where we will shift to where it's just the normal course that we're using AI. But right now, if you're using something directly with a patient that uses AI, you need to get consent. So we're all drowning in our inboxes, and this is a big problem. AI is coming to help. I think there's still some evolution there, but there are some AI tools that right now help more on the administrative end. So we'll on the staff end. We'll go to the next slide. And so there are tools, and I was asked to really talk about some really practical tools, which I like to do. Is there are tools for many EMRs. So the Oscar EMR with the Well AI Inbox, with the TeleCHR, with an AI powered tool, with Akiro, with the AI document triage, with Pocket MD, with their tools, and others. I couldn't put everything on here. They will take the eFax, the fax notes that come in that you've scanned into your chart, and they will connect that piece of paper, that fax note or that eFax, and automatically identify the patient from that, and highlight the patient, and highlight the clinician which this is related to. So it's related to me and my patient, Joe Smith, and then it will take that and automatically match it to the patient chart. And so that will save you time when these documents are coming in, and you've got either like a document that you need to match the patient, or you've got like a series of documents in the fax and you need to split it out. The AI will automatically split that out, and you'll be able to then match it to the chart. So this will save hours a week for your staff. And more help is on the way in terms of helping our own inboxes, where we get like duplicate reports and unnecessary things that come into our inbox. There's work to help improve that experience. We'll move to the next slide. AI scribes, you've heard a ton about AI scribes. So as a reminder, they take a conversation between a patient and a physician and make a clinical note. They save 3 to 4 hours a week. You really should be trying them out, to be honest, because it is such a game changer. And they are moving to do other things, like automatically booking an appointment for you, like sending a message. If, say, the patient doesn't have an email and you can't send them a notification to book online, it can send a message to your staff just from the conversation. You've seen a diabetic and you want to follow up in 3 months, it can automatically send a message to staff to say, book a follow-up appointment in 3 months. They can form referral letters. So you've talked to a patient about a referral, the scribe will automatically come up with a referral letter. As I will talk in the next slides, they can automatically fill forms, and then they're moving forward to helping with billing. So a rapidly evolving field with many functionalities that I think you will find quite helpful. We'll move to the next slide. And forms. So this is the bane of our existence. I dread when I have forms in my inbox to fill out. It's like the last thing I go to, just because it's so much work. And so there is AI that will fill out forms. And really, I don't think I need to speak too long to this. It will help take the data that we have in our charts, automate entry into the right fields of the form, no errors in terms of it'll leverage the data that's there. Now, there is still challenges with AI. AI does make things up. It hallucinates. So you still need to review some of these things, but it's really about editing versus like starting and doing it from scratch. It will make sure that the complete information is there in the form. Obviously, it does it a lot of it for you in terms of segregating things. So then you just need to review, and it will save time. And so we're seeing a number of different tools that will help with that. We'll move to the next slide. So this is just, again, examples, just very practically. There are a number of the scribe companies have moved forward in making these tools. This is one a company. There's a video there that talks a little bit to it. Now, you still need to put content into this. So this does not pull from your chart. You need to copy and paste from your chart into this platform, or you need to talk to the patient, and then it will actually fill out the form for you, and you can upload your own forms, and it will look to match the content to the fields in the form. So some describes, this is one of them. We'll move to the next slide. Here's another one of them that really does the same thing. This is an alpha, which means it's like not a full product, but you can sort of try it out, and then it will sort of move forward. But again, it just takes the information that you've put into it, and then we'll make the fill out the form for you. Now, as scribes mature and they integrate with the EMRs better, they will be able to pull some of the data, the historical data, but that's not there yet. But they will pull some of the historical data, and this will become a lot easier. We'll move to the next slide. Digital twins. So a digital twin is a representation of the patient in another place. So a copy of the patient data, and then that data is structured and conceptualized. So for example, Amazon has a digital twin of you. Amazon knows all about you and knows what you're going to buy next. Google has a digital twin of you. Google knows who you communicate with and what your circle is like. This is exactly that from a healthcare perspective. We are able to take the patient data, understand what is going on with the patient, structure, standardize all that data, and then do prediction for that patient. It's more personalized medicine for this patient. What would work based on the data, and so this can take that data and then fill out a form as well. And there's a scoping review on digital twins. We'll move to the next slide. And so there are platforms, digital twin platforms that are moving forward to do ODSP forms. So really sort of these things are coming and coming really quickly, where they structure the data, and then you can use the data for many different purposes, including filling out forms. We'll go to the next slide, which is, and here's some other form solutions. So there's a number of different companies that are developing form solutions. Take a look at them. Look at the ones that integrate with your EMRs. Look at other ones. Remember to keep those considerations in check. And there is help on the way. You don't need to do this all yourself. So ourselves, Ontario MD and Supply Ontario, will be releasing a list of vendors that AI scribe vendors that have met all the privacy security requirements. And I do anticipate with these other tools, there will be a process where we will review them and make sure they meet the privacy security requirements, and then have a list for you to pick from, versus like a free-for-all in terms of picking whatever sort of comes through the door. So very quick review of AI in a few different areas. There's much more coming, and I do think it's important to pay attention to this, because I do think it really will help you in your practice. So the next slide, we'll go to the next slide, which is the last one. And so happy to take any questions on any of this.
Amazing. Thank you so much. It's so cool to see just how much the space is growing, and going from scribes to now some of these additional applications of AI, and it just seems like it's continuing to grow and grow and grow. So thank you so much for guiding us through all of that and showing what's up and coming. So there actually are quite a few questions here, so we'll jump right in. So the first one is, in your experience, how do AI scribes handle bilingual or trilingual conversations? Are they able to do that?
Yeah, they are. I mean, it's interesting. I was talking to some physicians who practiced in the Ontario sort of Quebec area, and they were talking about franglais and how they have patients who speak French and English together. So there is some challenges with the scribes, but they are tuning towards that. And I know one of my colleagues speaks in Hindi to his patients, and they speak and it's able to beautifully take that and make it an English-based note. So I would say there's still some hiccups there, but they are getting better, and it does depend on vendor to vendor. So make sure you ask your vendor.
Great. So next question here is, do you know if the vendors are addressing the hallucinations in the AI tools? Just because it seems like it may be less of a time save if you're having to review every single note.
Yeah, and I found this, and I think it's like, I would suggest if you're trying a scribe, want to implement a scribe, try a few out. They are getting better, and so they're leveraging data sources. Many of his other data sources they have access to decrease the hallucinations that they're having. So they are, I've seen I've used it for a couple of years. I've seen improvement over time. So they are improving, but it still exists. So you will still have to, and it is your responsibility to review that note.
Yeah, absolutely. And there's another question here too that talks about, should you document that the note was done by AI, and, should there be a documentation that you reviewed it? Personally, it's in my practice that I do that. I just have a macro that actually is written automatically by the AI, and it kind of confirms that I've reviewed it as well too. I'm not sure if you do the same thing.
Yeah, very much. Yeah, you should list that it's written by the scribe, and I think the fact that you reviewed it, yeah, I think is good practice as well.
Yeah, and documenting it, as you said. Yeah. So in terms of that, definitely there is a process. I found too, like in my own experience, with time, the review becomes a lot faster because you just get used to how your scribe writes your notes and things. So even though it seems like it takes a lot of time to review it, I would just reassure the audience that it once you get comfortable with it and you're using it a lot, it is faster.
Yeah, and I would also say like take your time to look at the templates that the scribes have. Like you do need to spend some time up front tweaking it to the way that you practice. You know, some of it can be like quite narrative, but you can actually use templates that shrink it down to whatever you like. And the scribe vendors are very open to feedback. If something's not working, provide it to them because they will make their products better. But I think that's exactly right. Like you do get faster over time, and you know what to look out for.
Great, thanks. What do you estimate will be the cost for the physicians for implementing and using AI? Is there any sense of what that cost might look like for a practice?
So we are seeing it decreasing now. So if you look at like scribes, it can be from like $75 to a few $100s. I do think that there is a good possibility that some of that will be covered moving forward for physicians. So I think there's some good hope that some for AI scribes in particular that will be covered. I think AI should be a core part of the platform. Like you shouldn't have to pay more, and AI should be a way that the platforms just evolve. I know that's not the case. There's always third-party add-ons that the cost add, but I think that's where we need to advocate for our platforms to leverage AI because it really makes them function for us versus being, causing administrative burden. So I would say like probably like in the range of like $100 or so a month is where things are going to be, but to be honest, I think we're going to push to get those incorporated into existing fees.
Great, thank you. So another question just around like extra equipment or wiring, like is that typically something that needs to be done if you're going to be using an AI scribe, for example?
Yeah, very much. I think like you can test that. I would really make sure you test that, like test out your existing sort of setup. So for example, in our office, we've added some microphones, so some high quality microphones to help with that. So you do need a microphone, like you use the existing one in the in your computer, but you will need to sort of see how it works. I use my laptop. I now use my phone with an AI scribe. That's sufficient, to be honest, for the interaction, but it depends on your sort of clinic environment, how busy it is as well. They generally suggest having a microphone there and adding one to your setup.
Yeah, definitely. I've been similar as well too. Like I have an iPad, so I tend to just use my iPad to function as the scribe, and just that's honestly been working well for me. I haven't had to use anything else in my office, and even a phone, I found usually is good enough as long as the environment's quiet enough. So, but certainly, yeah, I have colleagues who have gone as far as like putting wired microphones into their offices and things like that. So it really just depends how far one wants to go, but definitely try it out first before you invest into that.
That's right.
In terms of another question here, so in order for AI to autofill these forms have to be online. So is there movement on that piece? Because it seems like if the forms are on paper, you can't really put that into your AI, right? Like let's say someone walks in with a form from Manulife or something like that, right? Like you don't have a digital copy of that. It's physical.
Well, some of them will take the P, like, yeah, you need a P. That's right. So like when you scan it in, it's tougher for the AI to actually make sense of it. If you have a PDF, that's a lot better. And so some of these solutions will take the PDF and then sort of fill the PDF, particularly like fillable PDFs are helpful. But absolutely right. Like we should not be using faxes. We should be digitizing these forms. And to be honest, not just digitizing the paper form, but making them easier as we're digitizing them. So there is movement in Ontario to look at e-forms and digitize different forms. So that is moving. It is slow, but you can still take a PDF form and use these solutions to fill it out.
Okay, thank you so much. So, there are still a few more questions, Mohammed, but I know you have to also get on your way too. So maybe what I'll do is I'll have you just maybe respond to them in the Q&A as well. And there were some requests too, if you could just put your macro that you were talking about that you use for the consent process, because I saw there was a question there about what do you, communicate to the patients to obtain their consent to use it. So if you can send that to us too, that would be great.
Will do. Thank you.
Amazing. Thank you so much for your talk. So next, we're going to move over to Norma to actually walk us through the ODSP specifically. I know all of us receive applications in our practices on a regular basis from our patients. So she's going to be speaking to us about best practices for these applications and some of the common pitfalls that can happen. So over to you, Norma.
Thank you. Great news about that AI, because I'll be quite honest, there is an online application that the ministry has issued for the ODSP application. So there may be some easier ways to do this even further. Let me just tell you a bit about North Peel and Dufferin. We're a free nonprofit community legal clinic. We're funded by Legal Aid Ontario. There's a total of 72 legal clinics in all of Ontario. And next slide, please. Next slide, please. There we go. Legal clinics provide poverty law legal services to low-income residents in their geographical area. North Peel and Dufferin's geographical area is Brampton, Caledon, and Dufferin County. There is likely a legal clinic in the geographical area where your patients live and where you practice medicine. Legal clinics represent a large number of clients who have ODSP appeals. If you have any questions when you're completing these forms, please feel free to reach out to either my clinic or the legal clinic in your area. If you want an information session as well to either yourself or staff, we can do that as well. So we can help you be able to complete these forms as easy as possible. There will be a resource that will be sent out at the end of this. It will have my contact information at my office, as well as a link to Legal Aid Ontario, where you can look up the legal clinic in your area. I want you to know it's free, and we don't mind you calling at any time. The purpose of today's presentation is to make the completion of an ODSP application easier and faster for you, and by explaining what exactly is being requested, as well as outlining some of the pitfalls so that you can avoid them when you're filling out these forms. Next slide, please. The ODSP definition of disability is the patient has a substantial mental or physical impairment that is continuous or recurrent and is expected to last a year or more. The patient's impairment directly results in a substantial restriction in their ability to work, care for themselves, or take part in community life. And the impairment, its duration and restrictions have been verified by an approved healthcare professional, which is yourself. Next slide, please. You'll recognize this slide. It's page 3 of the ODSP application. This is the slide that, this is the page that you will be filling out. There is a page 2 in the application that the ministry has provided that's been filled out with an example of the kind of information they're looking for. Couple things. This form can be typed out, or more likely you're going to use handwriting. One sort of suggestion is you're going to want to make sure that your handwriting is readable. A lot of times if it's not and it's illegible, then what happens is the disability adjudication unit can't read it and won't adjudicate on the condition, and the condition won't be entertained. Also too, I've seen this a few times. Please do not give this to your patient to fill out. I've seen this, and it causes great problems at hearings, to the point where the application can be dismissed. And what you're going to notice here in these boxes is that this is basically the ODSP definition. So it's really important that each one of these boxes be filled out. Next slide, please. This is the same page 3, only it's been completed. Let me go into each one of the boxes and areas. The first one is the medical condition. That's obvious, you put in the condition. The condition can be physical or it can be a mental health condition. You can have more than one condition in this application. I would suggest keeping the conditions in separate boxes. I know sometimes you have a number of conditions, you run out of space, so you plug them all into the same box. One suggestion might be to just, before you start filling it out, photocopy page 3 so you have sufficient space to put in all the conditions. Another option is at the bottom of page 3, just say see attached and further conditions, at which point you just take a page and make sure that you put in the next condition and fill out all the information that's required from these boxes. Next, I'd like to go down to impairments. Impairments are basically what are the symptoms this person's experiencing in regard to the condition. Next is the restriction box. What are they looking for? They're looking for you to identify things that your patient is having difficulty doing as a result of this condition. For both the impairment as well as the restriction, I suggest that you be specific and detailed because it's better and more effective. Couple pitfall for symptoms and impairments is avoid using the definition of disability language. For example, under impairment, don't put disabled, or under restrictions, can't work. What you're doing is you're wanting to explain why someone can't work. They can't bend, walk, sit, okay, versus the end result. Going over to the box with prognosis, it speaks for itself. You need to click off one of the 4 boxes there. Under duration of impairment, this is mandatory. And what they're looking for is this condition going to last less than a year or more than a year? If it lasts less than a year, there's no sense in putting the condition down. It hasn't met the definition. The condition must last more than a year. The idea behind that is that it's weeding out the short-term disabilities, illnesses people have, such as kidney stones. It's for more long-term conditions. Also, too, I want you to understand that they're talking about, is the impairment, the condition you've written down, is it going to last a year or more from when you're writing this condition down? A pitfall to that is sometimes I've seen applications where physicians have just met this patient, whether it be through a walk-in clinic or it's a new patient, and they'll put down less than a year because they haven't known the patient for very long. They're not talking about how long you've known this person. You could meet someone and then 5 minutes later put a form together for them. And what it is will this condition last a year or more? The last box there speaks for itself. Okay, you click off either it's recurrent and episodic or continuous. Again, these need to be filled out. This is where they're getting the verification for this condition to be even heard at a hearing if it goes to hearing. With the condition, I also want to point out a pitfall, okay? What you want to do is list conditions that are significant, okay? For example, high blood pressure, diabetes. If they're under control, you don't want to put them in there. Why? Because they're not significant. How do you know when it's significant? What I would do is ask myself, is this condition stopping this patient from doing any kind of gainful employment? And if in fact the question's answered with a no, I would not include that condition. Sometimes we get applications in and there's a massive grocery list, okay? You don't want to include stuff that really isn't even going to be entertained at a hearing because it's not even hitting the definition. Next slide, please. Next, what we have is the intellectual and emotional wellness scale. This is to be completed only when there's mental health condition that's been identified. If in fact in the application you don't have a mental health condition, you can move on. You don't need to complete this. If in fact there is a mental health condition, what you want to do is make sure that it is consistent with the information you've put in on page 3 under the condition. What they're interested in here is moderate and severe, which is number 2 and number 3. Number 2 and number 3 equals significant, which is part of the definition, or substantial. 1 and 2 doesn't equal the substantial definition. Next slide, please. The first part of this slide is dealing with a hearing impairment. A lot of times it's not even completed. If someone does have a hearing impairment, are they using a hearing aid? And is it putting the hearing within the normal function, within the normal limits? If it is, again, not really necessary to fill in. Going down to number 6, intervention and treatment. This is very important to complete. The first box is talking about hospital admissions and emergency room visits. What you want to do is, if there is any visits to the hospital that relate to the conditions you've put down, what I would do is just say, see attached, and attach the admission and discharge. It'll save you a lot of time. Otherwise, you can just fill it in, but you want to only do it in regard to hospital visits and admissions related to the conditions you have down. Next, below that is medications, current medications. Speaks for itself. What you want to do is list what the medications are in regard to the conditions that have been listed. If the patient is on other medications that are relating to other conditions not listed in this form, then what you don't want to do is include those. Next page, please. Activities, what you have here is treatments that people are going for. What you want to do is put down whether or not it's helping. Okay, there is a spot where it says describe response. You'll definitely want to fill that out. What you also want to do is if you have any reports that relate to any of these treatments, you'll want to put them in and attach them. Now, if there are no treatments, okay, under box 11 or the 11, it says if no, comment. It's important that if there's no treatments that are being done, that you actually add something in. Why? Because if there's no treatments, the ministry is going to assume that it's not very bad, this condition, because there's nothing being done. What you want to do is explain there's no treatments because, and there's a number of reasons why a lot of times there's no treatments. Sometimes you've tried all various treatments and none of them are effective. Other times, you know, it may be cost problems. There may not be the treatment in the area where you're practicing. There may be stomach issues. There may be addiction issues where you don't give them pain medications as a result of them using street drugs. What you do want to do, though, is put something in there, because a lot of times I see these applications not being accepted because there's an assumption being made by the ODSP office that this person isn't that bad, they're not receiving any treatments or on no medications. Under 5.2, what they're looking for there is past treatments, medications that they've been on, different treatments like counseling, pain clinics, etc. And what you want to address with those is why did they stop and approximately when did they do these treatments. In 5.3, what they're looking for is proposed treatments. They're looking for referrals that have been made to specialists, whether the person's on a wait list waiting for the specialist, or they're awaiting a surgery. That's the kind of information they're looking for there. All of this is very, very important information that you want to include. It's going to how bad this condition is and the severity of it. Next slide, please. Next, what we have is activities of daily living. You're probably thinking, why the heck do they want to know this? The reason is a patient's ability to do life's daily activities can translate into a potential ability to do work. And what happens is you want to make sure, again, consistency with what you're filling out here with the page 3 of the condition, okay? What they're, again, interested in is moderate and severe conditions. So it'd be 2 and 3. Because it equals significant or substantial impairment. A couple of tips for you. I strongly, again, recommend that you do not give this form to the patient to fill out. We have seen this a couple of times. It causes a massive amount of problems. What would be better is to either set up an appointment, go through this list with the patient to see what exactly the responses are and what difficulties they're having. Another option is to have the patient sit down at home and write out things that they're having difficulties with and to hand it in at your office. And you can use that to make it easier for you to fill out this part of the form. Something I also do want to highlight and make you aware of is sometimes patients indicate that they don't have trouble doing some of these things. And the reason is because they have someone else at home doing it. They either have family, a spouse, neighbors, kids. What you want to do is be aware of that, because sometimes they indicate that there's not a problem when there isn't a problem because someone else is doing it. Next slide, please. Okay, submitting a medical evidence. It's not a requirement. However, it can at many times be beneficial. What you want to make sure, though, is the medical evidence that you're submitting relates to the conditions that you have indicated already in the application. Some examples of helpful documents is test results, specialist reports, a medication history, and hospital records. Unhelpful is to put in a time period of your notes, your appointment notes with the patient. A lot of times it contains all sorts of irrelevant information, sore throat visits, bladder infections. Okay, you don't want to put that kind of information in. Next slide, please. I'm not going to go through this in detail because I've been highlighting a lot of reasons why applications are being denied. I'll leave that there for you to review later when they hand out the slides. Next slide, please. Okay, initial application is denied. That's where our office comes in. What do? We file an appeal for your patient. Next, what we do is we review the application to try and figure out why it was denied. And then we start to gather further medical information or evidence, which we review to determine what further information needs to go in. How do we do this? We send your office a letter requesting a copy of the patient's medical file for the last 2 years. We also will send out a medical report. There's 2 types of medical reports that can be requested, a short form medical or a full-blown medical. Our office has transitioned into the short form medicals. Why? Well, we know you're busy. You don't need to be doing full-blown medicals if it's not necessary. So what we end up doing is going through and figuring out, for example, say there isn't sufficient information on impairments of a condition. We'll send you a 1-pager that you just fill in a couple blanks, basically indicating what the impairments are. And we use that to try and clean up the application and try and get a reverse on the decision. We get a lot of reversals by doing this. I also want you to know this and feel comfortable with this. You're going to get these requests, and sometimes you don't support this application. Totally get it. Okay. Sometimes you have nothing further to add. If you get these requests from our clinic or any other legal clinic, what you want to do is let them know you have nothing further to add, at which point they'll stop following up and bothering you for this medical report. Okay. Please feel comfortable doing that. Okay. Lawyers have this sort of secret handshake we use. I had a case one time where there was a criminal side to this matter I was dealing with. I was dealing with a civil. I sent an email to the criminal lawyer and said, what's the deal with this? And basically got an email back saying it's a Crown's case. That was tipping me off to move on. Nothing further to discuss with that criminal lawyer. Have your secret handshake that you figure out with your local legal clinic to just let them know, nothing here, can't add anything further, and feel comfortable saying that. Next slide, please. This is just a copy for your information of our short form medical. Next slide, please. And that concludes my presentation.
Great. Thank you so much, Norma. That was really great, and I think a lot of really excellent take-home points. I know for me, the one that really stood out to me was not feeling the need to include every single condition on the reports. I was thinking of all the time I've wasted over the years putting absolutely everything in, and as you said, it's not helpful. So I know for me, that's definitely a take-home that I took along with so many others as well. For your Q&A, we're going to come back to it just because we're a little bit past time. So I'm going to just turn things over to our OCFP colleagues. They're going to do some announcements, and then we're going to come back to you for Q&A with a plan to wrap everything up by 9:15. So over to you, Jobin.
Thanks so much, Ali. And I'll try to be quick, but as everybody knows, the election's underway. The platforms are present. We want people to get out there. The one good thing is that everybody's talking about family doctors. And this is an important, it's become, Ontarians have made it an important election issue. And so this is important. Next slide. Just wanted to point out a couple of areas of small group learning sessions. The registration is there. We also want to have people, thanks, next slide, nominate their peers for the award. Next slide, yeah. This is the same thing we do every year. We really believe that this is a major part of what the OCFP does with regards to acknowledging our colleagues. Next slide. We did send out a member survey. We really hope people could consider doing it. It's an important one when it comes to continuous professional development. And we have the QR code here as well. We will send this afterwards, and it will be in the chat as well. This will take about 10 minutes, and there is a draw for a $100 gift card for those that complete. Next slide. I'll turn it back to you, Ali.
Great, thanks so much. So just as a reminder to our attendees, if you'd like to see our previous sessions, they're all posted online. These are some of the more popular ones that were highlighted and were well rated, so feel free to check them out. Next slide. So just as a reminder, we are adding an extra session. So March 7th is a new date. That's going to be the session that we unfortunately had to cancel a few weeks ago, which will be focusing on the new HPV guidelines. So please do attend all of our sessions. We love having you. Next slide. So as a reminder, recording and curated Q&A will be posted soon on the website. Our next community of practice will be on March 7th. And please don't forget to fill out the surveys. We really, really appreciate it when you do it. It takes just a few minutes and it gives us really valuable feedback on things that we can do to improve our sessions. And with that, we're going to go back to our Q&A. So I'll just ask Norma to come back. So one of the questions actually I wanted to ask, and it came up in the chat, it came up before the session, and it's coming up again now as well, is just around the role of the family physician in the ODSP process. So is our role to be advocating for the patient, or is it to be, sort of making sure that they meet the criteria and sort of advocating out from the ministry standpoint? Can you help walk us through that a little bit?
Absolutely. My position on that, and it's my opinion, okay, you shouldn't be advocating, period, for anybody. As a medical professional, you are completing the form using the medical information and test results that you have in your possession. Okay. What you don't want to do is all of a sudden be looked upon as being impartial. Based on the referrals that you make, based on the medications, etc., that is what the ministry is holding and looking at significantly. I would hold back on any kind of personal opinion, impression at all, because you're going to be perceived as not impartial. Leave the advocating to us, okay? Because your opinion, anything that you write will then become diminished. If you want to share your thoughts, a less obvious way would be use a lot of adjectives when you're filling this form out. For example, the client has pain or the patient has pain. You can use words like severe pain, a lot of pain. So it gets your point across without stepping across the line of being impartial.
Great, thank you so much. Another question here is that if a patient is not working due to a workplace injury and is having a hard time getting support from WSIB, is there any harm to the patient if we fill out an ODSP form while they are in the WSIB process?
No, not at all. In fact, if you have somebody with no source of income, the first stop you'll want them to go to is Ontario Works. They're not going to get a lot of money there, but it opens up a lot of better doors. First of all, it'll give them a source of income. And what they then do is tell the OW worker that they're unable to work, because the idea of that program is to get a job, at which point they'll do a referral over to the ODSP office. It'll be faster than if they just went directly to the ODSP office, at which point ODSP takes sometimes 6 months to make a decision once the application's in. So it at least gives them a source of income. Yeah, and quite honestly, a lot of times these claims with WSIB take forever and they're denied nonstop.
And I'm glad that you mentioned Ontario Works, because that was our next question here. So the forms for Ontario Works that come through to our office, should we be filling out the Ontario Works and ODSP at the same time? I've sometimes had that where they've come in with both.
Well, what happens, just so you know, the process is someone applies to Ontario Works, okay? They financially qualify them, at which point the idea is they have a meeting with Ontario Works and they want them to start looking for a job. Okay, if they say, no, I can't, I'm disabled, they send out a form with the client to you to fill out, which is called limits to participation. Fairly quick form. You flip out that, send it back. They see that the person, can't work right now. Then they end up sending out the ODSP application. Sometimes if you've got someone that's quite clearly not going to be working, they may send you the double form together. I just quickly fill it out. We tend to use the limits to participation as part of our evidence that we file on these appeals. We gather documents from OW.
No, thank you so much for walking me through that, because I've always wondered this. I've always had the forms, and this is the first time I actually got an answer on that. So thank you so much. That's really helpful, because we see them all the time and never understood why. So
verification. Everything is verification, verification. It's stupid because, you know what, someone hobbles into their office and it's like, oh, got to get limits to participation filled out. What a waste of time, but you know, whatever.
So there's a couple questions here actually just about the amounts related to ODSP, which I think is good information just for us to be aware of. So how much income does a patient receive if they are successful with ODSP?
Yeah, if it's a single person, right now it's gone up, thank God. It's now up to about $1,308 per month. Okay, if a person's on Ontario Works, single person, $733 they have to live on for the month, which is absolutely insane.
Yeah. Yeah, especially with like the cost of living and everything right now, inflation and everything. Wow. And then I guess the other thing that was asked that I'm curious about is there back pay? So will they back pay them to when the disability started, or is it just when the application was approved?
No, what happens is this: once the application is completed by the family doctor and sent in, once the ministry receives it, and it's a completed application, that's when the retro date starts. So if in fact, it doesn't go for hearing for, a year or two, that's okay. Because if we win the hearing, what happens is they'll go back to the date that the application was completed the month after, and they'll receive benefits. However, those benefits, whatever they receive from Ontario Works will be deducted. So if in fact they're on Ontario Works getting 733, the retro money will be 1308 minus the 733. So they'll get the difference in retro monies. If in fact they owe OW any monies, which is quite often, especially with CERB and that, people collected that wrongly. There's an overpayment. The overpayment with OW will also be paid off. A lot of times we used to see people getting a couple $1,000s. Recently, they're not getting too much because it's being taken by Ontario Works to pay off overpayments, etc.
I see. Okay, thanks for walking us through that. I'm just seeing here, we probably have time for a couple more questions. So one question here is, there's an issue that physicians are not always able to assess what a patient can or cannot do because, for example, we don't watch them doing laundry or dressing themselves or things like that per se. So how do we know if a patient can do something like that if we've never actually seen them do the task? Any recommendations on what we should be doing in those situations, especially when it gets to those like activities of daily living forms?
I'll be quite honest, this is the most goofy form, and you're put in such a stupid position. Like, you sit and ask the person, how they find going to the toilet and that, how they find doing laundry. It's ridiculous. That's why, I had previously suggested that you can either sit down and ask the person during an appointment with them. Other option is I've done this with clients where I've had them to just fill out what they can and can't do. Or if it's someone that's illiterate, I've done this before where I sit down with them and I have the dialogue with them. I put a form together, not even a form, a memo, and I say, bring this to your doctor. It'll help the doctor in completing the application. Very effective. But what you also want to flesh out is that the person is not having difficulties doing laundry because, their kids are doing it or their spouse or whatever. Because a lot of times, I see that where, they quickly, even if you sit in with them and you fill out the form, they tend to say, oh no, I don't have trouble doing laundry. I don't have trouble grocery shopping. They don't, because their husband's doing it or their wife's doing it.
Yes, yeah, that's such a good point in that clarification. And just so I'm clear, are you saying that you give them like a questionnaire to prepare them for that appointment with the doctor?
I actually suggest a lot of times that they sit down and write that out. And these are usually with the re-app. See, by the time we get the application, it's done. It's at an appeal stage. But I always suggest to people, take this form home. Here's a copy of it. Okay, go through it and write down what you have difficulties doing. And that will help you, because you know what a nightmare. And also too, I don't envy your position. When I meet with a client, once the hearing is done, we're done. Okay, there isn't this like ongoing relationship, and you walk a very fine line, because what you have is a form you have to fill out, and sometimes you're looking at it going, good luck with this one. So you have to fill it out because you have an ongoing relationship. But, as just a tidbit for you for future reference, what you might want to say to your patient is, because I used to do this when I was in the private bar, I'd blame our finance department. What you can do is blame the ministry. You know what? I have to fill out the forms the way, with all the medical information I have, and blame the ministry. It's the definition that's the problem. So it takes the monkey off your back, because it's difficult.
Yeah, definitely. And there were some questions that alluded to that as well. And I appreciate that answer to your first question, that, we have to be impartial, we have to be objective. And I think it's important that we communicate that to our patients as well, that, I can only be honest about what's going on, and it's the ministry's choice as to whether or not they approve you for ODSP. And sometimes even what I'll say is that, the definition of a disability from the ministry is pretty kind of specific. And so even though you may, have limitations and be disabled, it may not meet the criteria that the ministry finds as well. So it's not me saying that you're not disabled, it's the ministry that's using its own definition.
And I wouldn't even say that. I would say to them that, the ministry, they recognize you're disabled. It's just not hitting the level of the definition. Because a lot of times people feel like really mad because they think the ministry is saying to them they're not disabled. And it's like, oh, no. The ministry is not saying that. They recognize you're disabled. It's just not hitting that bar of disability under the definition. Also, too, I want to just throw this in before we sign off, is when you fill out, high blood pressure, high cholesterol, high sugars, okay, and they're not really significant, they're under control, okay, I want you to know that when I meet with a client and I see like 10 things down there and 5 of them are of substance, and the rest, I talk the client out of talking about the 5 that shouldn't be there. Why? Because we get 2 hours to do these hearings, and what I don't want to do is waste 2 hours on junk that's going nowhere. So I basically, that's my strategy always. I say, okay, the diabetes, it looks like it's under control. Your sugars are a little off. Okay, you're on metformin. Okay, are you suggesting that this diabetes is stopping you from doing any kind of gainful employment? No. Then maybe we should not include that, because it's a waste of time. So I talk them through it, and they agree it shouldn't be there. So you know what? Don't fill out those extra ones.
Yeah,
wasting your time, because I'm going to get rid of them.
Definitely.
I'm going to be honest.
Definitely. All right, and lots of appreciation for your talk, Norma. So definitely take a look through the chat, because again, this was just so practical and so helpful. And I think we all got something from that as well. So with that, I want to thank everyone for their time. Thanks for letting us run a little bit over today. And I wish you all the best. Stay safe during this season as well, too. Try and avoid the flu. Try and avoid the birds if you can. And we will see you all at the next session. Take care.